Okay, part two of the injury evaluation chapter. We're starting off with observation. So in the last section, we went over the background information and the history. So then the O in HOPS is observation. And observation, technically, there is no touching involved. Really, the observation is you just observing. What do you see? Observation really should start as soon as possible. So as soon as possible would be you as the athletic trainer on the sideline of the football field or on the basketball court, and you actually see the injury occur. That is ideal. If you see the person go down, you see the mechanism of injury, and you're able to observe a lot through that. Now, clearly that's not how it is going to happen all the time. So really, as soon as you make contact with the patient, that's when your observation is going to start. You're not solely looking at the specific joint involved, but their overall appearance. What is their gait? Are they walking to you? Are they limping to you? Are they being carried and completely not weight bearing? What is it about them? How are they actually getting to you? Are you in the athletic training room and they wander in by themselves and seem perfectly fine? Then you might, it's not going to be near as serious as if their two teammates are actually physically carrying the person in because they're not able to weight bear. The problem becomes a lot more serious at that point. What is their overall posture? Again, you can tell a lot from posture. Are they standing up straight? Are they limping? Are they compensating in any way? Is their head or neck turned to one side? Is it flexed? Is it extended? Is it twisted? How are they holding their shoulder? If you have shoulder problems, shoulder injuries, a lot of times you're going to want to cradle the arm of the shoulder that's injured because when it's just hanging at your side, it actually applies too much pressure, so that causes pain. So what is their posture? What is their overall function? Again, are they walking normally? Do they seem relatively fine? Not that they are fine, but it'll give you an idea, again, of how severe the injury is. We oftentimes, in the wintertime, someone comes in complaining of shoulder pain or upper extremity pain. We ask them to take off, their sweatshirt, take off their hoodie if they have a t-shirt on, because we can see how they take off their sweatshirt. If they just, no problem, swing it up, flip it off, it's no big deal. But sometimes when they're in more pain, they take one arm slowly out and then gently take it over their head and over their other arm. Obviously, that is a lot more of a painful injury than the previous one. The guarding, that does refer back to what I was talking about. Like if you hurt your shoulder, the weight of your arm actually hurts. So you actually guard it. You keep it close to your body. You use your own body as part of a splint when you don't want to move things. These things are really, they happen naturally. You don't really realize you're doing them. They happen naturally. But you want to note all of this. What is their overall posture? What is their overall attitude? What is their overall willingness to move, and how can they move? That's going to tell you a lot about the severity of the injury. So then that's just kind of the overall observation. Then you can kind of get an idea of specifically what's going on with this person. Are there any congenital or functional problems? We can answer some of these with the history questions, but take a look. And then if something does come up, you can ask them. Maybe they have, different muscle tone in their legs. Maybe they'll have a previous injury that resulted in that muscle weakness or that muscle atrophy. So what is going on with this person? And then again, looking at their overall gait. One of the major things that you're going to be looking at in observation is the deformity, the swelling, redness, signs of infection. Those are the primary things that we look for once we actually get to the joint. So obviously in this picture, I love this picture, we have some very gross deformity in the, this is probably this is an entire ankle dislocation or a tib fib fracture that's displaced. Very bad problem. You may have actually seen him do it, and you saw the mechanism, and then you also see the results. So you're looking for any kind of gross deformity or even a subtle deformity, but dislocations and things like that are usually pretty obvious. Other not as traumatic things, hemarthrosis, those are going to be pooling of blood underneath the skin. Then you have your edema, where you can actually try to assess how much swelling is in the area. Then you have general skin tone. Is there redness? Redness could be a sign of infection. What is ecchymosis? How bad is it? The amount of blood is not necessarily related to the severity of injury. There are some ligaments in the body that just bleed more than others, so you cannot necessarily say, well, there's not much bruising, that means it's probably not that bad. It really just depends on the area of the body to how much it bleeds. So ecchymosis is definitely something you're going to look at, but don't let that get in the way of your evaluation of severity. Any kind of scars. Scars are good to look at for number one. Are they surgical scars? That'll help indicate or remind you to ask the question of, have you ever heard this area before? But also scars are made up of connective tissue, and you'll be hearing about connective tissue consistently throughout the rest of the program. But scar tissue, when it lays down, it just continues to fill in. So sometimes when you do have scar tissue, it can actually get out of control and grow too much, and then end up causing a lot of problems with the underlying tissue, and ended up can cause decreased range of motion and some stiffness and things like that. So it's a good idea just to check and note any kind of scars that are in the area. And then obviously your signs of infection, you should have known those by now. Observation is also, I throw in some functional assessment in here because technically you are just still observing them. Functional assessment is you're going to ask them to do something functionally and see if they can do it. So if you find out in the history that the person is complaining of something specific, you kind of want to ask them to do it, because we want to see how they do it. Are they able to do it? At what point of the range of motion does it really hurt? We're trying to figure out what is wrong with this person, and sometimes asking them to do the painful things is important. So maybe in this case, in this picture, this could be, a single leg squat. Maybe 2 legs didn't really cause much pain, but we're trying to assess quad function. If you squat only on 1 leg, that's when we have pain. So now we're able to have more information because we asked them to do something more functional. Sometimes in the past, I've seen, those of you who were in lower last semester, the McMurray's test for meniscal tear may or may not always be 100%, accurate at diagnosing meniscal tear. So I have seen and actually done, I've had people who I thought may have had meniscus tear actually do like a duck walk, where they get into a deep squat and they walk forward. And if you can picture the McMurray's test, the duck walk is actually very similar, but instead of the examiner putting pretty minimal pressure on the meniscus, in the duck walk, the person is applying their entire body weight to the meniscus. So you may get a better reading, you may get a better result by doing something more functional. Then the third part then is palpation. Palpation is performed bilaterally. You always want to perform bilaterally. You want to assess, you want to apply the same amount of pressure to both sides, because there are parts of the body that even if they're not injured, if you press hard enough, they're going to hurt. So we want to make sure that when they say, yeah, that hurts, it's because the structure is actually injured and not because that spot is just tender. So if you bilaterally compare, then you're able to assess whether it's injured tissue or just a sensitive spot. Palpation is a skill. It's something that we're going to be working on consistently. It is not just poking around trying to find things. When you palpate, you should be able to visualize everything that you're on. That's the goal. You should know your anatomy so well that you're able to move in a very systematic sequence through the body and make sure that you're touching on the appropriate structures, not just randomly pressing on things. So there's 2 primary sequences that people do. The first strategy is to get all the bony structures, all the bony prominences, and then get the ligaments, and then get the muscles and tendons. That's not one that I use. I don't think that's, for me personally, I don't think it doesn't make much sense. I like number 2, where you palpate all structures in the area, and you make sure that you begin away from the area that's injured and move toward it, because this is more than likely going to cause some pain. We want to kind of get them ready, so we don't want to go first thing to the area where they said it hurts. Hopefully you ask the question, can you point with one finger where it hurts, so you have a very good idea of where the pain is. So stay away from that area, palpate around, making sure that you're getting all the stuff in the area so you can make sure that you rule everything else out, and then gradually work toward where they say their pain is. You are going to elicit pain. Palpation, especially with acute injuries, should cause some pain. You need to apply enough pressure that you can say without a doubt that yes, when I palpated, this caused pain, but when I palpated the same structure bilaterally, it did not cause pain. So make sure that you're doing palpation in an appropriate manner. So obviously, first off, you're going to palpate for point tenderness. That's one of the principal reasons that you are palpating. What structure is involved? But because you are touching the person, you're going to palpate for other things as well. Just by touching the person, you can feel for temperature. That's one of your signs of swelling. Is there increased temperature, or not swelling, inflammation? They might have an increased temperature in that specific body part. What's the swelling like? Maybe you can't see it, but if you feel it, you can feel that there's extra fluid in the area causing that swelling. Crepitus is that crackly, crunching sound that happens around tendons. Usually it's an inflammation of the sheath. So you can actually assess crepitus when the body part is moving and you're palpating the tendon. Obviously, any kind of deformity. You have to be careful. Don't palpate if it's an obvious gross deformity, but a lot of times, especially in football, one of the primary ways to diagnose, shoulder AC sprains and shoulder dislocations and clavicle fractures, they're all underneath the shoulder pad. So you really have to put your hand under the pad, to assess if there's any kind of deformity. Is the clavicle fractured? Is there an AC sprain? Is the shoulder dislocated? Because you can't see, so you have to use the palpation in order to diagnose deformity. Muscle spasm, you can obviously sometimes see, but oftentimes you're going to actually have to palpate to feel that there is muscle spasm. In order to assess cutaneous sensation, what is the skin sensation? Is it the same on both sides? Do they have decreased sensation in one area or not? You need to touch them. Also, to take a pulse, you got to put your hands on them, and just to feel the overall tissue density. Is there a change in the density of the tissue, possibly as a result of bleeding or extra fluid in that area? Could all change the tissue density of the injured site.